All right, well, in the interest of time, I'm going to go ahead and get us kicked off this morning. Thank you all for joining. And so, hello and welcome to our first Straight Talk About Stroke discussion. My name is Joni Guzman, and I'm the Mission Lifeline Stroke Director for the American Heart Association here in Montana. Thank you so much for joining today, either here or on Facebook Live. This is our first Straight Talk About Stroke discussion in what will be a series of ongoing public or provider education seminars on stroke issues. So before we get started, I wanted to mention some quick housekeeping items. First of all, closed captioning for this event is automatically turned on. If you would prefer to not have this feature, click the 3 dots near your camera controls and click Hide Subtitles. We have time for questions later on in the program, so please type any and all questions into the chat box. Make sure to click All Panelists and Attendees from the drop-down menu when using the chat box. I'd like to introduce Todd Mohr, our Education Quality Program Coordinator from St. James Healthcare and a co-chair of our EMS committee in Mission Lifeline, Montana. Todd Mohr. So Todd, thank you so much for coming today and presenting, and take it away.
My pleasure, and thanks for having me. What we'll be going through, and this is just going to be a quick 20 or 30 minute presentation, kind of a lunch and learn, but I'm not serving lunch, sorry. Is stroke assessment tools. So a little bit about my background. I'm a physician assistant. I work at St. James Healthcare in the emergency department, as well as Holy Rosary Healthcare in Miles City. I also do a lot of education and quality program coordination. I've had a very blessed background in EMS and now serve as EMS director for several of the best EMS agencies in Southwest Montana. I was a firefighter and have had the pleasure of serving as a helicopter paramedic and on the space shuttle rescue team, and also as a SWAT medic. So what I'm going to talk about today with stroke assessment tools affects all areas of emergency medicine, from our pre-hospital providers all the way into the emergency department to our neurologists. The way I present my materials is more of a story time. I don't drown you with data and feed you with a bunch of numbers that you don't need to remember. So I go through this rather quickly, and I didn't invent any of this stuff. These are the cool kids, these are the smart guys. What I do is try to bring it to you in a way that's understandable, or at least understandable for me. So we're all familiar with stroke, and what we're going to be specifically talking about today is ischemic strokes. And we all understand that time is tissue when it comes to just about anything that we're dealing with, whether it's myocardial infarction or shock or stroke. The American Heart Association has recognized this and has developed the American Stroke Association as well. And one thing that we found is our first diagnostic tool is going to be the CT scanner. And we're going to talk about time to CT and what our CT is going to show us and what our treatment options are after that. A lot of places have recognized the need for rapid CT, and now even have mobile CTs out in the field. I'm just waiting for my CT techs to be able to ride along with lights and sirens with us one of these days. So when we're looking at a stroke, I refer back to when I was a firefighter. We didn't worry as much about where the fire was or had been. We were trying to prevent it from going somewhere else. And it's the same concept with stroke. What we're trying to do is prevent any further tissue damage. As we know by the numbers, time is tissue, and the longer it takes, the more tissue we lose, the more neurons, as well as years of life. So the American Heart Association has these 8 Ds, or steps that we go through in stroke. What we're going to focus on today is the data portion. The first diagnostic tool and the most important diagnostic tool that we use is the CT scanner. What we're looking for is, this is normal, there's no bleeding, or we're looking for bleeding because that would be a contraindication to giving a thrombolytic like our TPA. And this shows an old stroke. So some of the history, strokes have been around for as long as humans have, but in the 1990s, we had a revolution with TPA, where we were actually able to give a medication that would go in and open up that clot. We've got a newer revolution or newer science that is showing that if we have a large vessel occlusion, we're able to go in and actually retrieve that clot and get that out. So that's going to be the heart of the talk today. What are we doing all these stroke scales for? Initially, we're looking at to see if it was a stroke and if they qualify for TPA. But now we want to know, is it a large vessel occlusion? Excuse me, say that 3 times fast. And how are we going to determine that with our stroke scales or our stroke assessment tools? Well, the rules for Montana for pre-hospital providers is our pre-hospital treatment protocols. These are put out by the Board of Medical Examiners. And what they say for stroke is that we should use a pre-hospital stroke screening scale. And I was surprised when I surveyed some EMS providers, and a lot of people don't do this or are not familiar with it or have not been taught how to do this. With chest pain, we need to know if we are having a heart attack. We've got a very great diagnostic tool with our 12 lead, and we can even look at our 12 lead and determine where that heart attack is occurring. However, with stroke, we don't have a tool like we do with an EKG. So we use a screening assessment tool. The problem is there's tons of them out there. I'm going to touch on a few of them and some of the characteristics, but this is more of an overview that they're out there, not to actually how to utilize them in the field. AHA does not endorse any one of these over the others, and that's going to be more of a conversation with your medical director. The gold standard, or the current test or screening tool that is the gold standard, is the NIH stroke scale. However, this is not very user-friendly, especially out in the field for pre-hospital personnel. If a patient arrives to a stroke center, the triage nurse or the patient's primary nurse is supposed to have this done in 15 minutes. But this is not something that can be easily done out in the field. The first thing we want to know, is this a stroke? The next thing we want to know, is this a large vessel occlusion stroke? And again, this is newer information that we're looking at. So looking at the first question, number one, we want to be aware of imitators. Is this a stroke or is it a migraine? Are they intoxicated or are they hypoglycemic? One thing that the AHA has come out with is FAST. But FAST was developed for the public to be able to recognize if this is a stroke and encourage them to call EMS to get to the hospital. For EMS, there are other tools that are available. The one that most of us are familiar with, that's probably been around the longest that I'm aware of, is the Cincinnati stroke scale. The Cincinnati stroke scale, when they did an impromptu poll, is used by about 70% of EMS providers. It gives you information based on facial droop, arm drift, or if they have slurred speech. And you can see if any one of these is abnormal or positive, then the probability of a stroke is about 72%. Some others that have been developed, the Los Angeles Pre-Hospital Stroke Scale, or LAPS. And again, studies show that this has a high degree of sensitivity and specificity. Another one that a lot of places are using throughout Montana is the B-FAST. They incorporate balance, eyes, or visual changes to your facial droop, your arm pronator drift, and then speech disturbance or slurred speech, and then last time the patient was known to be normal. The second question we want to know after we've determined could this be a stroke, is this a large vessel occlusion stroke? And is it large vessel or lacunar? Lacunar strokes make up about 20%, and they are in the subcortical area of the brain. Here we can see on an autopsy where a lacunar stroke had occurred. A large vessel occlusion is in the major arteries and affects the higher order brain function. Our Cincinnati pre-hospital stroke screen does not pick up if this could be a large vessel occlusion or not. Another benefit to current medical practice is we can now go in and actually retrieve that clot if it is a large vessel occlusion. And what studies are showing is up to 24 hours after the patient was last known to be normal. This is the interventional radiologist, and what they'll do is insert a catheter, go up through the arterial system into the brain and actually retrieve that clot. So how do we know if it's an LVO stroke? First of all, we're going to use our stroke severity score. Then we want to know if there are any signs or symptoms that may predict this, such as conjugate gaze deviation, aphasia, which is inability to speak or different disturbances of the speaking, more so than the slurred speech that our Cincinnati stroke scale picks up. And then agnosia, or inability to recognize objects. So some of the scales that have come out, and there's numerous, and I'm not going to go through all of them, I'm just going to touch on a few of them. One is the RACE score, and they incorporate some of these into the screening process. Again, our gold standard is the NIH stroke scale, and this will say where the equivalency is. It's just a shortened version of the NIH stroke scale. Another one is FAST-ED. Another one is VAN for vision, aphasia, and neglect. And then here's some studies on VAN on the sensitivity and specificity. Another thing is if we have a patient that comes into the emergency department, we're going to get a non-contrast head CT to see if they're bleeding in their brain. If we suspect a large vessel occlusion, we might at the same time do a CTA. We're going to do a non-contrast CT, then we're going to inject dye so that we can see the dye go through the arteries of the brain to see where the occlusion is. This normally is not done until later, but if someone completes that stroke screen that incorporates looking at a large vessel occlusion, like the NIH stroke scale or RACE, then we may do the CTA at the same time and save time. We don't do CTAs on everybody because that's not practical. Another scale is the LAMS, or Los Angeles Motor Scale, and this is used by Lifelight Network and Kalispell Regional. And then the nice thing is there's an app for that. So this is one area that you can go and download a free app, and you can use whichever your medical director and your local stroke center have decided to use for your area. This is an example of the steps that you would go through for the FAST-ED. And my understanding is that's what Missoula EMS is currently using. It's the FAST-ED. So which one is best? And that's the million-dollar question. A lot of people have looked at this and done studies on this, and the jury is still out. They show that VAN has 100% sensitivity, but this has not been completely tested for pre-hospital. But all of these are pretty good. So a lot of places have decided that they're going to use the easiest to remember in the heat of the moment out in the patient's living room while you're doing pre-hospital care for them. The main thing is communicate with your medical director and choose which one that you're going to use and use it. The other thing that's important about this, and it's not necessarily applicable to Montana, but I want to touch on this so you're aware of it. The reason that they've gone to this secondary screening or more intensive LVO screening is, for instance, if you're in LA or a major metropolitan center and you pick up your patient in this area, you want to know, do I want to go to a primary stroke center, which is closest, and they can do a non-contrast head CT and they can give TPA? Or do I want to go a little bit farther down the road, take that little extra time to go to a comprehensive stroke center where they can do a CTA of the head, a CTA of the head, consider TPA, but they've got a cath lab with an interventional radiologist that can go in and retrieve that clot and do a thrombectomy. So that's where all of this came from. Unfortunately, in Montana, the only place that's doing thrombectomies is in Missoula currently. The state of Washington, in their Stroke Alliance, when I had done some research on this, they have gone to a statewide consensus. And in the state, the first test that they do is FAST. And that's followed up for their LVO screening, they use LAMS. The other benefit of this is even if you do some sort of stroke screen and you're able to relay that information to the emergency department, you can put them on alert. They can notify CT that they've got a possible stroke coming in. So if they had a patient coming down from the floor, they can hold off for a little bit so it's not tying up the CT scanner. What we're looking at in Montana is coordinating Mission Lifeline and the Montana Stroke Alliance, working with the neurologists, the stroke centers, and the medical directors to potentially come up with a unified system here in Montana. But for the time being, work with your EMS director and make sure that you're using one of these scales. So as a short recap, the first thing we want to know, is this a stroke? Then we want to know if it's a large vessel occlusion stroke. We can use any of these stroke scales to help screen for that. We want to choose one and we want to use one. Again, the state says for EMS providers that you need to be using one of these scales and documenting it as well in your image trend. So, are there any questions that have come in, Joni?
No questions yet, but feel free, anyone, to please type your questions into the chat box. It's nice to have Todd here as an expert, so let's use him while we got him. Right, we did have a comment come in from Sean Opp, who says, it's great to see you after several years.
You too, brother.
All right. Oh, here's a question that came in. How many scales from Ellen or Penny here? How many scales and scores are available in image trend?
That is a good question that we will have to get back to everyone with. I don't know the answer to that.
Yeah, I'm not sure either. I do know.
Does Penny know that?
Penny asked it.
I know, but she might have asked because she knew it.
Oh, maybe she does. She's raising her hand.
Okay, I don't know.
Penny, can you come off mute? and talk.
I know that we had discussed it on our last meeting that you can have some loaded in for your service, I believe, as well.
Yeah, I think that they can put them in. And she did respond, nope, I don't know.
Okay, we'll find that answer out.
We will find that out, Spenny. See here. Any other questions for Todd? Thomas Price says, does Pulsara have some kind of stroke scale in it? Do we know?
That I'm not aware of, or I'm not familiar with Pulsara.
I know Pulsara, but I don't know the answer to that, Tom, but I can find out for you and let you know. Unless anyone else on the call knows. All right. You know, and Todd is correct. What we're working on in Mission Lifeline is potentially trying to regionalize a stroke scale to use. And we'll start with talking to our neurologists in our stroke centers and having them provide a consensus on one that is easily teachable and usable for even, you know, volunteer EMS. And then once that consensus is decided on the regional neurologists, then we'll talk to the medical directors and then have the medical directors come down and provide that information on which one to our EMS providers. Penny said, I'm pretty sure Pulsara does have a score or a screen, and it has a cost, which is an issue for volunteer service and sustainability. Yes, that is true. And Heather, maybe you can help. I don't know what to do when someone raises their hand. There's me letting you know what my literacy level is for this.
No worries. I saw a hand raised. So it was Ellen Clifton. So I enabled her to speak if she'd like. I'll just take everyone off mute who raises their hand.
Great.
This is Penny, and I raised my hand accidentally. I'm sorry.
Penny, I would value your insight and feedback on this first presentation that we did. I know you'll probably be giving some, and you are the true expert in this area for us.
Oh, Todd, stop it. Stop it. I think, you know, Peggy and I rolled out the VAN score in Eastern Montana, but we didn't get, and we ran it through our stroke committees, but our stroke medical directors weren't exactly what you would call engaged. Mm-hmm. But I think that we need to put it back in the court of the stroke medical directors at all of the primary centers and have them examine what they think is reasonable, feasible, teachable, affordable, et cetera, because I don't want, you know, I don't want anybody who's already using a scale to be forced to change, but we also can't have the volunteer people in any of the regions having to learn more than one scale because they're transferring to more than one place. So if we could get the stroke medical directors, Todd, to look at the scales and come to an agreement about what they might like to use, maybe one per region or statewide would be great. You know, that I think that would be the first step. I would imagine that many of us have rolled these out kind of on our own. So, and you know, we're receptive to changing to something that's for sure. We're going to be doing teaching for two years with EMS anyway, so we're receptive to changing. I just personally, and I think you and I have talked about this, I really have an issue with scores that have numbers with them for EMS. Glasgow Coma score is a big enough challenge, especially now that you have to adapt it to age and stuff like that. I'm really reluctant to give them a stroke score that has a number, which is what the RACE does. I would much prefer something that's yes, no. But let's, I mean, that would be what I would do, Todd, is go back to the stroke medical directors and have them talk amongst themselves. You know, none of them talk to each other. You know that, don't you?
Yeah.
Yeah.
And I think that's the benefit of Mission Lifeline. What we had seen with STEMI a few years ago, we're able to get a statewide consensus with the cardiologist, and I'm sure we'll be able to do that with the neurologists through this program.
Yeah.
And when we do get that, again, today was just an overview of the different scales that are out there. The main point is use one because it is helpful on the other end in the hospital, and important to document that it was used. And then if we do come to a consensus, then we can do another webinar, which is more in-depth for the specifics for that.
Okay.
Our hope is that we can get a consensus soon because we want to roll out our EMS Mission Lifeline Stroke education, and we want to find out from each region that we send our trainers to which one to really key in on, which assessment tool. So the goal is really within the next couple months to reach that consensus. Maybe a lofty goal, but we'll be working on that.
Awesome.
Yeah, wonderful. Well, thank you all so much for attending, and Todd, thank you so much for sharing your expertise. You're a great educator, and of course, thanks to Penny for chiming in too. Always a professional and expert.
Yes, thank you.
Yeah, we're going to go ahead and have this posted on our site, and I'll send an email out to everyone that's attended or registered so you'll know where to find it. And I just want to remind everyone to go to montanastroke.org and register for our statewide stroke conference, the Rocky Mountain Stroke Conference coming up. We'll do it lunch and learn style as well within an hour, over 6 weeks. So head in there and register for that. Thank you all for attending and have a wonderful day.